Hello, Dr. Mishra. Thank you so much for joining in today. And I really thanks a lot for investing your valuable time with us. And today we are going to talk about some very important topic, which is probably it falls below the radar for a lot of doctors. So we are going to talk about hyperparathyroidism. So parathyroid hormone, and many of you have probably not even thought of that hormone in a while. Dr. Mishra is actually an endocrine surgeon. So Dr. Mishra is the head of endocrine surgery at the Sanjay Gandhi Postgraduate Institute at Lucknow. So for those of you who don't know, that's a premier institute in India. And earlier in another episode, Dr. Mishra talked about his great experience in telehealth in India. That was so exciting. But today here, he's going to talk about endocrine surgery. So for some people, it becomes a little confusing, not doctors, but those who are not doctors, the difference between an endocrinologist and an endocrine surgeon. So an endocrinologist is someone who does the medical part of it. So an endocrinologist doesn't do any surgeries, but Dr. Mishra is an endocrine surgeon, which is a much rarer breed. So Dr. Mishra, please will you introduce yourself very briefly and then we'll move on to the slide.
Okay, thank you, Dr. Carr. I've been working here for the last 31 years. I came here from Postgraduate Institute, Chandigarh, after my training there, to start a new department of endocrine surgery, which was very new in those days in 1989. The concept of endocrine surgery was not born in India, but somehow this institute was built with the concept of creating super specialties. And in fact, they hesitated to start this department to the initial phase of recruitment of faculty. In the third phase of recruitment faculty, they realized that we should do something for this specialty. Anyway, that's the history. So now it took about a lot of time, about 10 years to really reach at a basement to get some patients, so-called endocrine surgical patients. So we carved out from general surgery, from oncology, from urology, except pituitary, which is the domain of the neurosurgeons. So we operate rest of the endocrine glands in the body. So now we are established department and we are just celebrating our 31st anniversary tomorrow. And we have contributed. Yes, thank you. So we are the first department to start a postgraduate training program. That's called MCH, Master in Chirurgy in Endocrine Surgery, way back 20 years ago, and which is recognized by the Medical Council of India. So after that, 3 other departments have started endocrine surgery in this country, and they're also running a similar kind of certified program for 3 years training. So there's a little bit difference in training out here on western part of the world, in Canada or in US. They have fellowship programs, and it's not 3 years, it is for 1 year or maximum 2 years. So anyway, it is a question of semantics, whether you want 3 years or 2 years, 1 year, doesn't matter, but you have to do the surgery very carefully. Endocrine glands are not so big glands so that they can be visible from outside or from somebody can palpate it. They are basically hormone producing tumors. They manifest more in terms of the symptoms rather than in terms of the signs. So you have to find out where they are. And parathyroid in that sense is one of the unique examples where I think you'll be discussing today, even without symptoms, you have the disease. So we have to really dig out disease from a healthy, so-called healthy individual. So I'll enjoy the talk as you go along. Let's start.
Thank you, Dr. Mishra. You actually absolutely hit it on the head. So what we are going to talk about today. So I am a functional medicine specialist, and I'm just going to start the. So Dr. Mishra, when we come to your slides, would you rather that I can progress the slides and you can just tell me, or if you want to, I can.
No, you can. Yeah, you can progress my slide as it comes.
Okay. So
you take the control, no issue.
Okay, thank you. So I'm a functional medicine doctor. So basically what we are going to talk about today is, mine is more a perspective of primary care physician. So in the functional medicine world, we are called the super generalists. Whereas in India, sometimes the primary care physician is either a family doctor or even an internal medicine specialist. So today my perspective will be more from the point of view of what, number one, when should you look for parathyroid, hyperparathyroidism? And next is when you find that, what are the things you can do from primarily a primary care perspective, because the important questions are, what are the things we should look for, and when is it absolutely necessary to refer a patient to an endocrine surgeon? And as Dr. Mishra said, so Dr. Mishra, how many endocrine surgeons are there in India? Because I think it's a very rare breed.
If we include our alumni and some other departments, it will be around, say, 30 to 35 now.
Wow. So 30, 35 in a country of 1.3 billion.
Yeah.
I'm sure, I hope some, new upcoming doctors are listening to this. That's a major area. So moving on to, and I don't want to spend a lot of time on the basics. So this is just an overview of what some of the things are that we're going to talk about today. Basically, as Dr. Mishra, you mentioned that many of the endocrine glands are very small. And I don't want to spend a lot of time on the physiology because I'm focusing more on the clinical side. So what I understand is the parathyroid glands are extremely small normally, right? They're about the size of a grain of rice, right?
It's called, you can split bean size.
Okay. And I have personally never seen a
interesting.
parathyroid gland in my life, as I'm sure many of my colleagues have not seen either. So basically, Dr. Mishra, will you just highlight very briefly what are the main functions, the chief ones being maintaining serum calcium and phosphorus levels, and highlight a little bit about parathyroid and vitamin D. And the third area I'm just going to mention a little bit. So Dr. Mishra, over to you.
Yeah, so the parathyroid hormone is a very important hormone in the sense it controls so many functions, being a small gland, but it controls big organs like the entire bone, skeletal mass is controlled by the parathyroid hormone. Without a parathyroid hormone, I don't think you could have really have bones. So they help in mineralization of the bone in terms of the depositing calcium. To get the calcium, it helps in absorption of the calcium. So starting from absorption calcium from the diet till it is depositing in the bone, it has all the role. At the same time, it helps in both even degrading the bone, depositing the bone, everything else. So you should understand the high dose of PTAs can also cause degradation of the bone that we call reserve from the bone. But at the same time, normal parathyroid hormone requires for skeletal growth. And second thing is it has a role in many other organs indirectly, not directly, but indirectly. But the target organs are kidney and the bone. And vitamin D is another hormone. It is called vitamin, but peculiarly it is also called a hormone because vitamin D very crucial role, especially vitamin D that you get in the diet is not active vitamin D. It has to convert to active vitamin D in the kidney. So 125 vitamin D3 has to become 25 vitamin D3. Then it come back and act as a agent to help in the absorption of the vitamin, this thing, PTS. So PTS secretion. So PTS secretion. So the target organ is in parathyroid. So vitamin D, 25 vitamin D acts in the parathyroid. So it is PTS acts on the intestine, whereas vitamin D, after it's getting active form in the kidney, goes back and act on the parathyroid hormone. It's a kind of axis that goes around. So this is the only hormone. Please remember, it's the only hormone. It doesn't depend on the master endocrine gland, that is the pituitary. Otherwise, the rest of all the hormones, they are controlled by the master gland in pituitary. But it has escaped. It doesn't care who is pituitary. So it acts in the bone, parathyroid, and the intestine. Circulars like that. And at the same time, and the bone and the kidney, they are the targets for or damage if there is a hyperparathyroidism, because they can cause problem in the kidney in the form of formation of the stone, because of high calcium, they cause stone formation. Stone formation can lead to the lot of problems due to kidney failure and all those things. So patient can land up in kidney damage leading to the secondary renal failure. So, and the primary organ is in the skeletal organ. There's a direct target, but there are indirect target also. I mean, the parathyroid also is called cardiotoxin. I think we are going to talk about the hyperparathyroidism and the heart. So there is a gentleman who was a nephrologist in the US. So she was very much, he coined this term, which is very much into the relationship PTH and heart. And he used to call it, PTH is a cardiotoxin. I heard his lecture in a Japanese city in Kyoto. I think Kyoto. So the first time I heard that PTH is a cardiotoxin. So PTH has effect on so many other organs. So also vitamin D. You might have heard about vitamin D having a role in even cancer in the colon. It acts all over. Now even vitamin D, just like screening calcium, now vitamin D is getting screened for the for public health, and vitamin D is now getting supplemented in the diet. So there are very, very important things. That's why vitamin D is called a hormone. So now coming to the little more complex of the vitamin D also plays a role in suppressing the parathyroid hormone secretion. So that is a relationship we have to understand between the primary and secondary. So when the secondary renal failure occurs, then the renal failure occurs, the secondary effect on the parathyroid. So it's called secondary hyperparathyroidism. So primary is something different, and secondary is something different, and then another called tertiary hyperparathyroidism. So when secondary becomes autonomous, becomes tertiary. So where is secondary hyperparathyroidism is because of the renal failure, and renal failure fails to kind of secrete the vitamin D, active vitamin D, because the active vitamin D is product in the kidney, renal tubules. So when kidney fails, then active vitamin D is not formed there. So there is nobody to put a check on the in the parathyroids. So then they kept on secreting more and more, and you'll find high PTH. Then it is behave like primary hyperparathyroidism. So you will find in secondary hyperparathyroidism there will be bone loss, etc. But the cause is kidney. But in primary, the cause in the parathyroid itself, that is like any other tumor, they're autonomous. And in the tumor, you also must be going ahead and seeing about the adenoma that you're talking of. After some slides I mentioned about adenoma, there can be also hyperplasia. In the sense, all the 4 glands are affected. But in the adenoma, usually you get one adenoma in one gland. There can be multiple adenoma, but very extremely rare. So you have to understand primary hyperparathyroidism because there is a tumor or hyperplasia in the parathyroids. Secondary hyperparathyroidism because problem in the kidney. So that's why we got secondary effect on the parathyroid. There are other causes of problem in the hyperparathyroid due to the multiple endocrine neoplasia. That is again another terminology because genetic problems. So we can talk about that later. So let's go to the next slide.
So just one thing I wanted to mention here. So in relation to parathyroid hormone and vitamin D, as you rightly pointed out, vitamin D is a hormone, not a vitamin actually. So if I understand correctly, in relation to parathyroid, the most important role that vitamin D plays is in the absorption of calcium. Am I right?
Yes, sir, right.
Yes. So why I wanted to highlight this is, as you know, that a lot of people are, recommended calcium supplementation, particularly women, because I was primarily an OBGY. And back in the days, we used to give quite a high dose of calcium. So what happens is if vitamin D is extremely low, which is very common in India, I think 95% of people don't have adequate vitamin D if they're not supplementing. So supplementing with high dose calcium in the absence of normal optimal levels of vitamin D is not a great idea. Just wanted to mention that. And Dr. Mishra, this is the parathyroid being a cardiotoxin. That is the first time I've heard that term, but it is true. This is something that we hadn't known a lot about before. So the relationship of heart disease and stroke risk in relation to the parathyroid hormones. A lot of people are not really aware of that, but I just want to highlight that because many of you are doing preventive, health checkups and things like that. And I don't always see a parathyroid hormone in that list. So this is again, parathyroid and vitamin D. This is so intimately related. And given that, we talked about the low vitamin D3 levels in India. So one of the things that I do is when I check patients the first time, I usually do not check the parathyroid because I know if they have a low vitamin D, the parathyroid may be high, and then like I am going on and testing everything else. So Dr. Mishra, would you recommend that first we need to optimize vitamin D3 and then focus on the high parathyroid, or is it like we should look at all of it together? What is your opinion?
Very nice question you have asked, actually, because this is very relevant for developing countries. For Western countries, they never thought about that there can be a vitamin D deficiency, actually, because most of the parathyroid articles are never mentioned. Neither in any case of hyperparathyroidism, they used to investigate for vitamin D. Let me tell you, this knowledge has gone from us or countries like us. Yeah, I'll share you some of our old papers. In fact, it's the second paper, the first paper again from India, second paper from us, where we have estimated vitamin D. That time the facility was not there estimating vitamin D here. So we used to collect some sample and we collaborated with a physician from Detroit and Henry Ford Hospital. So he took the samples from here and we estimated there. This is the first paper published in one of the prestigious journal of American Society of Bone Mineral Research. And gentleman is called Sudhakar Rao. Many people in the medical field must be knowing him. Dr. Sudhakar Rao from Henry Ford. So we have a paper, common paper, way back about 20 years ago must be, where we first time showed that the relationship of vitamin D with the parathyroid cell growth. That question came because our parathyroid tumors are bigger size when all these reports from Western countries were smaller size. They report in milligrams and we saw in grams. So we tried to find out what is the reason. So your question is absolutely pertinent. You used to see so many cases of vitamin D deficiency, especially when you do this measurement in patients of parathyroid disease, primary hyperparathyroidism, number one. Number two, of course, this phenomenon is changing. In my paper that we have been quoting now, in that paper we have said 3 decades. In 3 decades, this trend has changed actually. That's because improve in the nutritional parameters or nutritional status of the population. So the vitamin D is more and more now normal when you detect them. It comes in 25, something like that. Previously used to give 7, 8, 10, like that. So this is changing. Our paper is based on that, the 3 decades thing. So vitamin D relationship with parathyroid is so important because it has a relationship not only on deciding on supplement to the diet in developing countries, but in your country, also in Canada, also in the US, also all the countries where there is too much of winter. Why I'm telling so? So when this paper came, after that you'll find many papers coming up from the Western countries, because when you have too much of cold for a long time, then, and usually you get parathyroid disease a little later in the year, little 4th decade, something like that, 5th decade. So these people are not exposed to the sun. So that is natural source of so the sunlight is the source of vitamin D, right? And they're not exposed to the sun. And so when they tested for vitamin D, they found there is deficiency in vitamin D in their patients of hyperparathyroidism. So vitamin D estimation is never part of the routine test in investigating for primary hyperparathyroidism in Western countries. When they found out this phenomenon there, they started doing that. Now, point number 2 is why it is important to have vitamin D estimation. Because as you know, that low vitamin D can result in the hyperplasia of the parathyroid, right? So now they'll secrete more hormone, increasing parathyroid hormone. So when you see the vitamin D is low, then the high parathyroid hormone obviously needs to be investigated further. I think there is a slide in later as you go along. So when you just find high PTH doesn't mean that there will be always hyperparathyroidism. There are other causes. At least in our country, I have sent so many patients back to the physician when I suspect that I think there's the element of vitamin D deficiency, and when you do vitamin D estimation, you find very low. Now, why that suspicion has occurred? This cannot be primary HPT because other manifestation of the HPT, primary HPT, is not there.
Mm-hmm.
So I become suspicious on that. Then when you did vitamin D, it is low. So now it might be, the same case may be a primary parathyroid, but not at that point of time, I should put a knife on that. So this patient was given supplement of vitamin D, and we again estimated after 6 months. And we found the parathyroid hormone has come down to low. Of course, it is not in all cases, but a couple of cases we have observed that. And we have deferred surgery in those patients.
So just one point, because in the interest of time, I'm going to cut short a lot of the things, because vitamin D, low vitamin D is so common in India. So this reminds me of a patient, vitamin D supplements. People in India sometimes think that once they have taken, for 12 weeks, that it will automatically remain high forever. So that is not true. You need a regular supplementation. So I had sent a patient, I remember, to an endocrine surgeon, because I assumed she was still on vitamin D and she had forgotten to take her vitamin D for a long time. So the next question is, who are the people we are going to screen for parathyroid hormones? So serum PTH. Number one, symptomatic, and I'll come to the symptoms. And as we mentioned about, high risk for cardiovascular disease, heart disease, stroke, people who are taking lithium. So lithium is given as a psychiatric medication. So those people are at a higher risk for high parathyroid. Anyone who comes with a high serum calcium and kidney stones and radiation treatment to the neck. Now, why I highlighted kidney stones is because kidney stones are so common. So Dr. Mishra, would you say that every patient with a kidney stone at the first visit would need a parathyroid screening, or should we only do it for recurrent kidney stones?
Yeah, I think you answered this question. First is recurrent kidney stones, and then bilateral kidney stones. These two are very important. And somebody has got a nephrocalcinosis on both sides. So that those persons, first do a calcium. We don't go stop. We do not go PTH estimation straight away. At least in our country, we first do calcium, minimum 3 calcium, and phosphorus, and alkaline phosphatase. So you find that derangement, then you go for PTH.
Yes, I'll come to the lab testing a few slides down the line. Also, we are going to discuss a little bit more about the low vitamin D and what you should do when you find a low vitamin D and a high parathyroid. That is a slide little down the line. So back in the days, Dr. Mishra, we were taught that stones, bones, groans, and psychic moans are like symptoms of hyperparathyroidism. So that would be mostly hypercalcemia, right? And Dr. Mishra, given your long experience in this, is it true that, and you're going to talk about that in your paper, that you got more of these high symptoms during your earlier days versus now, as you mentioned, when people are screened a lot more? So how common is stones, bones, groans, and psychic moans now versus what it was maybe 20 years ago?
I mean, I'll show you the couple of slides ahead. So these symptoms are are very common symptoms. You get musculoskeletal problems mostly, and even you used to get very, very advanced disease about 20 years ago. We get fractures in the skeletal systems, multiple fractures, bone tumors, the shoulder tumors. We don't see those days nowadays, actually. So the trend is changing. It's changing, going towards your Western countries, where many people are mild symptomatic or asymptomatic. So we get mild symptomatics or moderate symptomatics, I can say. Asymptomatic are very few.
Okay, so Dr. Mishra, maybe I'm going to, challenge the thing of getting the asymptomatic ones. Maybe the asymptomatic ones come to people like me. They don't go to you. So what are the symptoms of hyperparathyroidism? As you can see in this list: chronic fatigue, just don't feel well, difficulty concentrating, focusing, depression, anxiety, bone loss, insomnia.
All of them.
Sorry?
All of them.
Yes.
All of them.
Yes. And insomnia, irritability, brain fog, heartburn, kidney stones, chronic kidney disease, high blood pressure, cardiac arrhythmia, headaches, palpitations. Now, I just, as a doctor treating women, I just want to mention something that in India, postmenopausal, perimenopausal women do not always have hot flashes, because that is more common in Western countries versus in Asia, as you mentioned in your paper, and we're going to talk about that. Musculoskeletal symptoms are a lot more. So often, I think, Dr. Mishra, women are told you're just getting old, and this is why you have all these whole list of symptoms of pains and aches and this and that. But sometimes it is possible that we are missing a high parathyroid as well. So I just want everyone to understand what are the red flags that should come out when you are looking at a woman with all these symptoms, men as well, but I treat more women than men. So just wanted to mention that postmenopausal women in Asian countries have a lot of these symptoms, not so much of hot flashes. So if you're looking at a postmenopausal woman and you're thinking, she's not complaining of hot flashes, so it's not menopause. So it could be, the presentation could be very different. Then the next thing comes is diagnosis of primary hyperparathyroidism. So Dr. Mishra, as you mentioned, let us say many patients go through an executive health checkup or a yearly health checkup. And many people think that, that can detect every possible disease on earth, which is not true. You and I know that. So what are some of the lab tests you would recommend? So number one thing, of course, symptoms. And the next, I have this list in two colors, and I'll tell you why I have them in two colors. Now, given the fact that in countries like India, patients have to pay for all the testing from their pocket, versus I'm in Alberta, I work with physicians here, where patients don't have to pay for all the tests from their pocket. So how many of these tests would you say, which ones are the primary importance and which could be probably, discretionary or maybe not for everyone if they have a problem of, spending a lot of money?
Serum calcium,
okay.
phosphorus, alkaline phosphatase,
okay.
and 125 vitamin D. And we used to do not 125, we used to do vitamin D3, not 125.
Yes, so that's what I'm asking, because 125 costs, I think, a lot more than D3.
Yes, just D3 is enough for us.
Yes, and is it necessary to do an ionic calcium even if we find that serum calcium is normal and high parathyroid hormone is there?
Yeah, I must say that actually when we do all these three tests, calcium, phosphorus, alpha, we also do serum protein. Because serum protein, especially albumin, you have to be very careful because while calculating the exact calcium measurements, does help.
Yes.
Because low albumin can give a wrong figure of calcium. And usually in suspicion cases, we do 3 times this test. And without putting a clamp in the arm, and we do it in the fasting state. And of course, ionic calcium also do in, again, in some selected cases. Again, that is not available in all places.
No.
So whereas it's serum calcium, we can do it. And let me tell you, if there is a mild symptomatic disease, even with ordinary calcium also it will be high. I still insist just calcium. If the calcium is raised, then you can check by doing repeat calcium alphas, and also check it by the albumin. That is enough, I think, to take you straight away to PTS instead of going to ionic calcium and all those things.
Thank you, Dr. Mishra. So I'm just stating this again. In the ideal world, we would like to do all these tests: parathyroid, D3, proteins, calcium, alkaline phosphatase, and 125 ionic calcium, everything. But if all these are not possible, so at least serum calcium, and if you have suspicions, then you need to repeat it. Of course, parathyroid and vitamin D3 vitamin D3 is tested almost, I think every patient in India has a vitamin D3 test being done now. And a part of the executive health checkup or any of those checkups, serum calcium is usually done. Next thing comes, Dr. Mishra, given that the parathyroid glands are so small, what would really show whether there is a parathyroid adenoma? So an adenoma is a benign tumor of the parathyroid. Would US ultrasound examination of the neck show it if it's very small?
I'll just, Dr. Kaur, one thing I forgot, I just want to mention it. In terms of screening for calcium, for parathyroid, one thing is pancreatitis. You might have heard about pancreatitis.
Yes.
One of the cause for pancreatitis is also hyperparathyroidism.
Oh, that is very interesting. I didn't know that.
Yeah.
Thank
so
you,
yes, you must. because many cases we get from gastroenterologist, maybe in a year, 4 or 5 cases, they detect hyperparathyroidism when they do a routine serum calcium. And let me tell you, that can sometimes misguide you also, because initially it may be low or normal, but later on it can be high. Because when pancreatitis occurs, you might have heard from your MBBS knowledge, is saponification of the fat there.
Yes.
So usually calcium is absorbed there, entangled with this thing. So actual calcium measurement will misguide you. But if somebody has got a real hyperparathyroidism, really causing high PTH, so definitely the calcium will be raised. So you pick up also calcium, hyperparathyroidism in case of pancreatitis. So one should, this is for information only. So a gastroenterologist can pick up. Same thing with psychiatrics, we have already discussed.
Yes,
So
I will come to that.
The message that I want to pass on to you and everybody is that we have to suspect,
Yes.
Otherwise we'll miss.
Yes.
Otherwise we'll miss. Please go ahead. So
I
your
fully
next
agree
question
with
was,
you, Dr. Mishra.
yes.
So,
in the
yes.
soul, you just discuss about the postmenopausal women. There also you have to suspect.
Yes.
You just cannot just pass it on. I must recommend at least all postmenopausal women, you must do a calcium, and just don't pass it on. Okay, you'll have aged or something like that, or
Yes.
you may be having some rheumatic problem. No, please. In rheumatology clinic also, I insist them, please get a calcium done. So you can also pick up some cases.
Thank you so much, Dr. Mishra. That is something we have been talking about, but a lot of people don't give that the due that is due to it. So yes, just I'll briefly go over imaging. Is it necessary to do a technetium system EV scan for every patient with high parathyroid? Okay.
No. So see, please remember one thing, any endocrine conditions, especially functioning endocrine conditions, the biochemical test is very, very important.
Okay.
The biochemistry is the indicator to localization. Why you do localization? Localization means if there is a tumor you suspect, you have to operate or take care of that. So ultrasound is not done for diagnosis. That thing one should know about it. So the primary hyperparathyroidism is diagnosed biochemically.
Okay, so we need not do any of these imaging studies. And particularly when, something like an MRI or a CT costs so much, and I think even the technetium system ED scan costs a lot in India. So it is not wise to invest money in those testing because it's just going to, make the patient spend a lot of money without getting adequate information. And ultrasound will not detect small tumors. Am I right, Dr. Mishra?
Yes, you're right.
Okay. Next is how important is it to do a bone test? So I'm just going to explain the DEXA scan and the urinary enterobacterial. So DEXA scan is what everyone is familiar with. You go into a machine. There is radiation exposure, and again the urinary enterobacterial. Now, why as functional medicine doctors we like the NTX is number one, it is non-invasive, no radiation exposure. And it's a simple urine test. And I know it's available in India as well. More importantly, it costs a whole lot less than a DEXA scan. So Dr. Mishra, my question to you is it enough to do an NTX and know about bone health, or is it necessary to do a DEXA scan? In the ideal world, yes. In countries like Canada, they have routine DEXA scan every 3 to 5 years. But in a country like India, where patients have to pay for their health care, would you say that doing a NTX would be enough, at least to get a sort of a baseline idea about bone health?
I just want to answer this question in 2 parts. First, when you order a test, you expect some information from that test, right? Mm-hmm. Otherwise, clinical diagnosis was there 100 years ago, there's no test. Decade ago or 2 decades ago, 3 decades ago, what is standard normal has changed over now. Yes. So a lot of influence of industry and a lot of influence on the dependency on tests has reduced our acumen for clinical perception of any disease. Now, second part I want to discuss, that we should not chase the endpoint. First, find out what is my primary disease. Mm-hmm. If you're talking of DEXA or the tumor bone markers like NTX, those markers are important, whether it's radiological marker or biochemical markers. That is only important to know whether the bone has been affected, how much is affected, mm-hmm. or if there's a tumor, you want to reverse changes. So you can compare preoperative DEXA with the post-op DEXA. So first, my diagnosis is not yet achieved. So these two tests doesn't help in your diagnosis. As I told, repeat, your diagnosis depends on your calcium and PTS, right?
Yes.
And to do PTS, you should have at least calcium, phosphorus, and alphas, or calcium. So two times, 3 times is all high. The phosphorus may be normal, doesn't matter. If the calcium is high, straight away, or ionic calcium is high, straight away go for PTS, your diagnosis is made. Now you find out which are the 4 glands are affected. Either it is a single gland or multiple gland, all those things require this imaging technique. And DEXA is required that time also, not to diagnose hyperparathyroidism, just to find out how much the hyperparathyroidism has done damage to the bone. That's the point.
Thank you, Dr. Mishra. So just a clarification, here we're talking about parathyroid. So in relation to parathyroid adenoma detection and hyperparathyroidism, it is not necessary to do a DEXA scan or a urinary NTX at the beginning of the workup. However, many patients go through a bone assessment for general health, because in my world of preventive medicine, bone health, mobility is one of the major parameters for long-term health. So in relation to parathyroid, if you're looking at only parathyroid, you do not need to do a DEXA scan or a urinary NTX right away. It is much more important to rule out whether there is an adenoma in the parathyroid and refer to the patient to the right person. And we'll talk about that in a little while. So just a little clarification. Now, Dr. Mishra, in relation to parathyroid levels, I think most labs in India consider 65 picogram per ml as the upper limit. Now, do you agree with this paper where it says that the upper limit of normal should be different for people who are younger?
I mean, your yes and your no also. So what I meant to say is, what is the sacrosanct number 65? Any number? Yes. Do you think the 64 is normal? Yeah. 66 is abnormal? I mean, it's not like that, because you have to standardize a particular test, right?
Yes.
So if you take the standard deviation on each side, it can fluctuate to either side. And definitely age has a role to play. But at the same time, what I mean to say is, when you make a standard for an abnormal level of test, so you do random sampling of so many thousands of people, then you make a standard. But at the same time, the parathyroid hormones keeps on increasing slowly in the subclinical level or suboptimal level. So there are even research done in some countries I know, they reduce the standard deviation for another by 5, say 60. So you will find there are a couple of cases they have observed after 5 years, they develop frank hyperparathyroidism, some of them. So this level is definitely important to see that, otherwise you level everybody as hyperparathyroid. So standard is 65 and above is a diagnostic of hyperparathyroidism. At the same time, if you find in a younger individual or older individual, then little bit of here and there, you can wait. You can doubt it, you can wait. No issue. But saying that this age has influence on the parathyroid hormone level, I mean, is of research interest. But in day-to-day practice, we cannot make okay, for old, this is the level, for young, this is the level. It's not
another
like
quick question, Dr. Mishra. Given that, women and men are very different, do you think the levels would be different for a woman? I don't think I've not seen any
don't discriminate sex, gender here. I think you see, as for PTS is concerned, gender neutral.
As far as we know, we don't know yet.
You are punishing, let me tell you, you are punishing the women's sex so much disease you have given them. I mean, I really feel pity about that. I think all the victims of disease are women, talk of thyroid, at least by endocrine diseases. Thyroid is common in women, parathyroid is common in women. So these two are more important diseases, endocrine, and there are so many other diseases you are given more to the women. Now also a little bit of immune is there about cardiac system, that is also now given equal figures.
That is another area that I really love. So anyway, I mean, one of the things that I usually talk about is we were so used to, so back when I was an OBGY, we used to just tell women, who are past their middle age, oh, you are just aging, so just get used to it. Now things are very different. I obviously, maybe I have grown older, but I'm not happy to feel unwell and achy and pain and, brain fog and any of that. So obviously times have changed also. But my point is, it's very easy to tell a woman, you know, it's all in your head, or don't worry, you're just becoming older. There are reasons for people to feel things. Anyway, moving on to calcium. Dr. Mishra, at this rate, we will continue talking for more than 2 hours. So calcium levels, again, age factor, I think we'll just ignore the age thing. Supposing a patient comes with, you know, serum calcium levels about 9 this year, 6 months later, for some other reason, they've had a serum calcium done and it has reached 10. It has not gone beyond the, you know, the laboratory levels. Would that be significant? Someone like that, do you think we should check for the parathyroid and everything else as well?
I think we know very well Dr. Carr is asymptomatic hyperparathyroidism, NORMOCALCEMIC hyperparathyroidism. So in this situation, you have to see the symptoms. How much, especially these kind of people have more musculoskeletal problems. Yes. So if they have, we should not ignore that symptom actually. We should do alphas same time, or repeat the calcium and repeat ionic calcium. These are the indications where you should go for specific tests of ionic calcium. Though it costs more, I'll go for ionic calcium in this condition, and also see the protein and do a calculations and reach a particular figure. And the symptoms dictates my next action to label this case as NORMOCALCEMIC hyperparathyroidism, unless and otherwise proven otherwise.
Thank you, Dr. Mishra. So this is just my rant. So serum calcium levels are extremely tightly controlled. Now, why I'm saying that normal levels do not reflect bone health. So back in the days when I was an OBGY, we used to recommend calcium supplements to, you know, all women. And sometimes I'd find women telling me, doctor, my blood calcium is normal. So I have normal bone health. And why should I take calcium? So this is just my aside that I wanted to mention is, for those of you, you're looking at your labs and you see a normal serum calcium, that doesn't necessarily mean that your bones are okay. Bones are way more than vitamin D and calcium only. So for bone health, we'll have a different session. So next is, Dr. Mishra, I call this the Indian problem of, you know, the 60,000 international unit vitamin D3 capsule. And given that, you know, with the ongoing coronavirus pandemic, a lot of people are taking super high dose of vitamin D3 every day. So what happens is, again, just a little clarification, because the 60,000 international unit capsule is available over the counter in India, in countries like Canada, you won't get this without a prescription. And I've had patients going through all of these. So some of them, what they ended up doing is taking 60,000 every day instead of once a week. And given the ongoing coronavirus pandemic, many people have started taking the 60,000 every day. And Dr. Mishra, you must have come across some patients who have done this in your practice.
Yeah, usually I'm not seen somebody taking every day. But we prescribe them when we found somebody is hypothyroid, hypovitamin D. When we discharge the patient after parathyroid surgery, so we gave them one sachet. We don't have a capsule. We have a sachet. One sachet is containing 60,000 units. You give them every day for 1 week. Mm-hmm. Then after that, every week for 6 months, mm-hmm. right? Then once in a month. Even now also, I take once in a month. Mm-hmm. My vitamin D also low. So, yes.
Dr. Mishra, I'm going to interrupt you in the interest of time. So vitamin D, how to supplement vitamin D, we'll talk about that on another day, because basically it depends on the baseline serum vitamin D3 levels. I have a blog post on this. I'll post a link on that. So what are the other causes of high serum calcium? We have already briefly mentioned. Diuretics and lithium are the big ones. So multiple myeloma, sarcoidosis, Paget's disease of the bone, these will not remain asymptomatic, but just moving ahead. So this is a question which is, I think, very vital for primary care providers, is high serum calcium, low D3, high parathyroid. So what are we going to do? I think I'll just move ahead to this slide. So my question to you, Dr. Mishra, is someone comes with high parathyroid, normal serum calcium, low D3. We supplement with vitamin D3 depending on what their levels are, and retest after 3 months. So would you agree that the 30 nanogram per ml level is the level of vitamin D3 we need to look at in patients in India as well, because some of these numbers I think are from Western countries. So should we look at 30 nanogram per ml as sort of the optimal level before we repeat a parathyroid test?
We do that around 25, 30, that is the range.
Okay. So 25 also would be acceptable.
Yeah, acceptable.
So I'm just stating this thing again. So you find a patient, high parathyroid, normal serum calcium, low vitamin D. You give them vitamin D, let us say for 3 months, 60,000 once a week, or whatever, 50,000 once a week, whatever it is that you're following. After 3 months, repeat the vitamin D3 test. If it has reached about 25 to 30 nanogram per ml, and the units are different, some of the labs report in international units.
International unit, yes.
Yeah, so nanogram multiplied by 2.49 is international units. When you find the vitamin D3 level has reached this kind of a level, then repeat the parathyroid. Because if, again, as we have discussed before, if D3 is low, parathyroid may be high and you're not going to get the right picture. Now, the thing is, if parathyroid is still high and serum calcium is normal, and we have ruled out things like diuretics and lithium and all that, then what are we going to do next? So that is where, Dr. Mishra's, knowledge comes so much in. One thing I wanted to mention is diuretics, maybe we may be able to stop for a short time, but lithium is not easy to stop for many patients who are bipolar or any of those psychiatric conditions. This is just an aside, but if the patient is on lithium and you are just chasing the parathyroid, you may be chasing the wrong target. This is what I want to tell the audience. So I think one slide was there before that. So high parathyroid, normal calcium, this is something we're going to come to. So Dr. Mishra, would you suggest that any hyperparathyroidism, after ruling out low vitamin D3, even if calcium is normal, we need to rule out a parathyroid adenoma?
Yes, certainly, because there is a condition called NORMOCALCEMIC hyperparathyroidism.
Yes. Okay, yes. I'm going to move ahead. So the next thing is, parathyroidectomy improves cardiovascular risk factors. So as we talked about earlier, high parathyroid, as Dr. Mishra said, it's a cardiotoxin. And I think back until a few years ago, we didn't have enough studies to tell us whether the surgery would improve their risk factors. But this is a fairly new paper, I think 2019. So Dr. Mishra, would you agree that this is what you are seeing, or you're waiting to do the study for that?
I think it is well proven now that even the so-called risk criteria or consensus statement of operating patients with minimal symptoms or asymptomatic hyperparathyroidism, it has gone so many years of grilling now, and the fourth round of consensus is over. I think we are pretty clear now that is now proven, well proven. If you have got asymptomatic hyperparathyroidism, don't wait. I think this is definitely a risk factor on the heart. And let me just correct the terminology that we just discussed about that. This cardiotoxin term was not introduced by me. This is introduced by a gentleman called Dr. Zlatopolsky.
Yes.
Zlatopolsky, right? So he is a US-based nephrologist, and I happened to attend an international symposium on PTS, just PTS. Yes. The international symposium held in Kyoto many years ago. So I was there. Few surgeons among plenty of nephrologists and physicians, endocrinologists. So I heard the term there. In fact, I heard the term first time in my life that PTH is called cardiotoxin. Now it has been proven after so many years that it is definitely toxic, even if it is secondary hyperparathyroidism, CRH, chronic renal failure, if you have high PTH, you must take care of that.
Yes. Thank you, Dr. Mishra. No, what I meant is you were the first person I heard talking about cardiotoxicity. Yes, definitely. Thank you for acknowledging the person who came up with the term. Now, this is something very interesting, because we have been, in functional medicine world, we've been talking about parathyroid for a while, but a lot of other, even fancy hospitals with, executive health checkup don't even look at the parathyroid. So I know I'm not going to waste any more time in saying that there is a problem of underdiagnosis of primary hyperparathyroidism. That is one message we want to give across to all of you. If you're not looking at parathyroid, serum calcium, vitamin D3 together, this is the time to start doing it. So now I'm going to hand over to Dr. Mishra to share his experience on parathyroid surgery and all the different, his experience is for many years. And if you're interested in knowing more about Dr. Mishra's research, you can go to ResearchGate. I think, Dr. Mishra, all your research is on ResearchGate?
Most of them.
Yes, okay. So I have shortened the presentation a little bit from Dr. Mishra's wonderful longer presentation. So this is the paper, and this paper is available on ResearchGate if any of you would like to go ahead. And so Dr. Mishra, over to you.
Yeah, what I just described a couple of minutes ago about our 2.5 years of experience, we try to categorize in the 3 parts and 3 cohorts we took up. We have seen how this disease has evolutionized in our experience over the last 30 years here. So we took these 3 figures. You can see here what we observed. This trend is increasing. This trend is increasing not because that the disease is increasing in incidence. No, it is a detection. It is basically a detection of the disease, because as I told you, you have to suspect, then you have to treat, then you have to diagnose, investigate. So all these things are improved. When I started practice, there is no PTH estimation available, right? So we suspect only on the calcium and the bone disease. You used to get many symptomatic disease. So calcium is enough, calcium alphas, and we operate. But nowadays we are getting even very minimal symptom disease with getting full diagnosis with all investigation available everywhere. And we have a system of couriers. They send samples to some specific lab in big cities, they get the reports. I must say that I used to always tell my fellows, so your life is so smooth nowadays compared to our time when we used to always poke our eyes into the skeleton, and no skeletal survey is done nowadays. You know, you can diagnose biochemically. So that's one. Can I go next slide? So the disease is increasing because of the detection, not by incidence.
Thank you, Dr. Mishra. Just one question about so AHPT is asymptomatic hyperparathyroidism. So typically what would be a patient's history who's asymptomatic? So usually is it the clinicians, who are more astute, who would look at parathyroid even in the asymptomatic?
Actually, the term, let me tell you, if you are labeling 100% as asymptomatic hyperparathyroidism, if you really poke more deeply into the symptoms, you'll definitely find there will be few who qualify for asymptomatic. Let me tell you, in a very strict term, the asymptomatic will be the patients who have been routinely screened, like after 70s, 1970, you are getting routine screening in a routine health checkup every 2 years. When you find a person having high calcium, they repeat that calcium and do PTS, then you label that this is a case of asymptomatic hyperparathyroidism. Otherwise, if you ask them, they will have all vague symptoms, some mental illness, something like that, as you have just described. So it's very difficult to say actually very strictly that one is asymptomatic. I must say that minimal symptom, that is a better terminology to be used. Minimal symptom hyperparathyroidism. So let me just tell you, we should not be bothered about asymptomatic or minimal symptomatic. Somebody has a hyperparathyroidism or no hyperparathyroidism. That is more important.
Thank you. So Dr. Mishra, just one comment on, so the average number of parathyroidectomy even until 2016 in your tertiary center is only 26.7. So again, would you say that this is gross underdiagnosis?
Yes, you're right. Underdiagnosis. So I really, how much I used to really feel desperate. Why in Western literature they're getting so many cases? Why are getting so many less cases? Well, that happened because only to detect those conditions, they will not come straight to the surgeon. But you are the people who you first diagnose it. You are looking at the primary level, or somebody is an endocrinologist or internal medicine people, or people in the community hospitals. They have pick up cases. So you need to educate them. Who are the patients? You should screen them.
Yes. So this is
you can find here in the slide. Yes. Yes.
This is the reason I'm bringing out these videos, so that I want people to be aware of what are the things they need to check. Now I highlighted that male is to female ratio because 1 is to 2.3. So whole lot more women in not just your cohorts, it's also worldwide, Dr. Mishra, am I right?
Yes, you are right.
Yeah. And so given that, you know, the middle-aged women so often complain of all these things, and very often, as I said, you know, they are dismissed by being told it's nothing really you need to worry about. Just one question, Dr. Mishra, this difference in age, 39 years in the
Yeah.
first decade and 47 years in the
Yeah, that,
third decade, what
yeah, rightly
would
caught this.
explain
Yeah,
that?
rightly caught this thing. Yeah, why I'm telling you, this is a very important point you should know actually. So that time also used to look at it. Why you are getting in early age? Why in Western figures are in fourth decade and fifth
Yeah.
decade? Let me tell you frankly. If you see this trend here in 3 decades, so we are approaching to your standards. So more and more cases are now coming up in higher age group. And I'm sure in another 20 years, will exactly match with Western figures actually. And why in the young? Because all the symptom people used to get it in last 20 years are symptomatic disease. So
Mm-hmm.
all symptomatic disease, we're missing all those minimal symptom disease of elderly population.
Yes.
So only the symptomatic people come to us, and so the age difference is coming here.
Yes, a lot of
I mean,
people.
this is a relative thing. Yeah, yeah, it's a
Yes, a
relative
lot
thing.
of people were told, don't worry, it's really nothing very important. Now, this is a very interesting slide, Dr. Mishra. So musculoskeletal, as you've been saying, has been much more, the symptoms have been much more, much higher in your cohorts. Urological, gastrointestinal. So urological would be mostly kidney stones.
Yes, there are kidney stones.
And gastrointestinal, what were the commonest symptoms that you?
This is, as I told him, pancreatitis.
Mm-hmm.
You know, pancreatitis is one of the commonest thing.
Mm-hmm. And
So that is the first thing. Yeah,
neck
not
mask.
dyspepsia. This neck mass. That is an interesting point. Because
Yes.
see, we have published a paper where we found in the benign disease, usually you get neck mass in malignant parathyroid.
Mm-hmm.
Rare condition, of course. So there you get palpate the glands actually. And in fact, it is written in textbook. The diagnosis of parathyroid carcinoma is based on 3 factors. One is the neck mass, very high calcium. You know, these are the things that we talk of the carcinoma. Whereas in our conditions, in benign conditions also we get neck mass, palpable mass. Not like neck mass, big mass, but you palpate, you'll find there.
Mm-hmm. That
There
is
is
very
parathyroid, there
interesting.
is swelling.
That is very
But if you see
interesting.
but Dr. Carr, if you see in the last cohort, you know, the third cohort, you'll find
Yes.
this neck mass incidence is coming down.
Yeah, it's a lot
Yeah.
less now. Yeah.
So I mean, same thing also. It's on, you see the musculoskeletal used to have fractures, bone tumors. Those
Yes.
things are also coming down.
Yeah. So
Yeah.
neuropsychiatric Dr. Mishra, I just want to focus a little bit on that because mental health challenges have become so much more commoner now. And many of these ladies, they're just put on an antidepressant or an anti-anxiety medication without really focusing on the cause for this. So what were some of the neuropsychiatric symptoms that in your cohort you found?
I think all these things that you just described, you know,
Okay.
lack of concentrations, not feeling well, not feeling energy to work, you know, so that is vague pain and ache and disturbing mind all the time. There's a sense of not feeling well. You know, it's very difficult to unless you are a psychologist.
Mm-hmm.
For ordinary physicians, it's very difficult to understand actually.
Yes.
So it is important for the psychologist, psychiatrist to pick up those cases there.
Yes.
So that is very, very important. So the so-called moans, groans, and everything is still valid.
Yes.
But people have to concentrate. But all these symptoms of moan, groans become 2-3 specialties. So all these specialty people have to understand there is a condition called primary hyperparathyroidism. There's no harm in just ticking one calcium parameter. That's all.
So there were some unique findings in your study. So what were the unique things that you found? So.
Yeah, that's exactly I made in the bullet points here. Most Indian patients are symptomatic. That is obviously everybody knows about it. Recently, considerable decrease in the clinical and biochemical severity of the disease that you have observed. You don't get so much high calcium. We don't get so much of high PTH nowadays. This trend is coming down and it's coming almost towards like Western countries. And the severity of disease also has come down. You don't see much fractures nowadays. There was a time when you should do skeletal survey. Now it is not done at all. Only somebody has a fracture, which is very rare. Then the crisis, palpable neck mass, pathological fractures, totally now completely decreased. We hardly see any of them, very rarely. then significantly lower mean PTH level, as I just described, and alkaline phosphatase. They're all indications of high bone turnover, alkaline phosphatase. You don't see that much disease unless you DEXA. With DEXA also many patients we found that normal, not so low. But previously each and every patient will have -2 or -3 like that. So now it is almost gone almost.
Okay. So the next question, Dr. Mishra, is when should a primary care practitioner refer a patient to an endocrine surgeon? That is my number one question. Number two question is, given that there are so few endocrine surgeons and you have a virtual consulting at your institute, is it possible for a patient from a remote place in India where they don't have an endocrine surgeon to access services of anyone online? So, Dr. Mishra, your video has gone. Anyway, so when
just could you just break for 1 minute? I think there's a problem with the charging. Yeah, I'll just take 1 minute, one second.
Okay, no worries.
Just break it now. Yeah.
So while I wait for Dr. Mishra to get his phone charging taken care of, this is actually a very important question on when should you refer, because I have had experiences in the past where I would, do all the stuff that we've been talking about so far, check the serum calcium. Serum calcium is trending up, and I would refer to an endocrine surgeon. And then sometimes the endocrine surgeon would say, no, we can wait and see. And the patient comes back and says, my problem is really not that great. But this was my experience a few years ago. And as Dr. Mishra mentioned, I think things are changing a lot. So even endocrine surgeons have a lower threshold of, when to do the surgery and when to absolutely rule out parathyroid adenomas. So my point is, it is important to do that for your patients after you've done the basic work, after you've ruled out, low vitamin D3, which is extremely important. So Dr. Mishra, over to you. When should a patient be referred to endocrine surgeons?
Yeah, but before endocrine surgeon, if you are talking of primary care, they should send the patient to endocrinologist first. Okay. That should be my approach actually. Unless you have investigated and you have found that high PTH and high calcium, all those criteria there are fulfilling, then you can send directly to endocrine surgeon. It depends on your health system, how it is done actually, because you may find maybe in 99% cases you are already right, diagnosis of parathyroidism, but there will be some odd cases, where lithium and all the things are there, giving you a wrong figure of high PTH, or vitamin D deficiency. So better to send it to some endocrinologist first, then they will send to endocrinologist, unless you are very much sure about the diagnosis.
So Dr. Mishra, I think we have kind of answered this question. So when it is symptomatic, I'm just reiterating the symptoms once again, because a lot of these symptoms are non-specific. Chronic fatigue, just don't feel well. These are also symptoms of things like, low iron, and iron deficiency anemia is so common. So I'm just reiterating the same slide that we had discussed before. And as you said, there are no asymptomatic patients. It's usually that either they've not been screened well or they have minimal symptoms. So all these patients, people with something like high blood pressure, Dr. Mishra, high blood pressure is so common in India, and I'm not sure how many of them have actually been screened for parathyroid. So again, this is from one of the guidelines that I came across, and this is my personal opinion. This is a little elitist for a country like India. Would you say that? Would you say that we can do with less in India because of the conditions of where people have to pay for everything?
I don't think it's possible to go for. No, it's not possible. I mean, those guidelines I've been following for last 4 occasions. They've done the 4 guidelines has come up now. So I am looking at this thing, even the 4th consensus development, these all matches to our indications. So ultimately they have come down now. For the same condition, they used to say that wait and follow up. They themselves are saying, even if all your visits are sponsored by your insurer and the total care taken care by the insurance, still you are feeling your burden is so much, and you say that better to go operate rather than watch. And the physician himself or herself prefer to report to patients to the surgeons rather than keeping in the clinic and follow up. Because who is going to take the risk? Yes. Now somebody asks you that why I'm getting a heart attack? Because you did not advise me for surgery. I would have been better now.
Yes.
So nobody is going to take a risk now. It is, so the fourth consensus statement now coming up is very, very clear nowadays, whom to operate and whom to not operate. So for the so-called asthmatic hyperparathyroidism, when the first consensus statement was developed, is totally now different in the fourth consensus statement.
Okay.
More and more cases, broadly speaking, one-liner, more and more cases are going for surgery. Patients are asking for surgery.
That is very gratifying to know. So Dr. Mishra, as I had asked, is it possible for patients to access virtual care to endocrine surgeons? Is there a website where this information is available?
So I will prefer not, yeah, of course, there are many websites available for information to the patient. It's better to identify a person or endocrine surgeon and take a one-to-one consultation rather than putting blindly in a website, asking for opinion. I mean, that may not be a better options actually. And find out, even overseas also, though, for example, we have no license to practice in Canada, but, you know, one can take a second opinion from somebody and reach out some diagnosis kind of thing. But what I meant to say is virtual consultation is possible, but not in the way that you are asking, putting in the website and getting the answer. It is better to find out a person.
I didn't mean putting on a website. I meant, is there a list of all the endocrine surgeons in India somewhere where, you know, patients can look if anyone is there nearby?
Yeah, yeah. You see the publication. The best way is to go to publications.
Oh, okay. So publications. So that is, again, I think that the way we do in India is usually ask our friends and colleagues, you know, do you know an endocrine surgeon? And we refer to them.
I mean, everybody is endocrine surgeon. Every head and neck surgeon is endocrine surgeon. Nobody will see that they are not. So, I mean, the way you define in Canada or in US is different in India.
Thank you, Dr. Mishra. And what you said rightly about the guidelines is so important, because a few years ago, I have had frustrating experiences when I send my hyperparathyroidism patients to endocrine surgeons. They come back and said, no, the doctor said I don't need surgery now. You know, I said, no, you need another opinion, I think.
Yeah, yes.
I'm just going to summarize what we talked about. So when to screen. So Dr. Mishra, I will say that everyone needs to be screened. Will you agree to that?
I'll little modify that. It depends on the age of the patient and the symptoms that you have in a primary care setting. And the second care setting, when the patient is having like pancreatitis or some kind of rheumatic problems, or patients are having this coming to the clinics of psychiatrists. So if they're going there, what in the primary care is very important, where those routine checks like weakness, etc., lack of concentration, that is the main point to at least screen. Calcium should be a screening test for that actually, and you can pick up those cases, right?
And I think one more thing I'll stress upon is recurrent kidney stones is another big one.
Sure.
That is so common, and a lot of people don't look at that. And we talked about D3 deficiency and high parathyroid and how to deal with a patient who has that condition. Then we talked about when to refer to an endocrine surgeon. And so when do patients benefit from surgery? So Dr. Mishra, back in the days in my fellowship, we were taught that, you know, many patients with hyperparathyroidism, because of an adenoma, do not realize how unwell they were. So after the surgery, many of them have said, I didn't know how unwell I was. Now I'm feeling so much better. Does that reflect your experience as well?
Actually, I was going to tell the same thing what you have just spoken actually. So you'll find the patients will completely be different after surgery in the day one itself. You know, in the day one itself, I have seen that patients feel so better. They say that I'm feeling very well. They can describe.
Yes.
We're just feeling well. That's all, you know. Unless somebody has a bone pain.
Yeah.
The bone pain is the first thing that recovers in the day one.
Wow.
So when I go to the ward after surgery, I ask the patient, how do you feel? I feel a little less ache now. So, but the last thing that is going to come up is a psychological condition. That takes a little more time. Like concentration, that takes more time. But the bone pain, muscle weakness, etc., recover very fast actually. Blood pressure reversal is very, very doubtful condition, because, you know, in the heart, when there is changes in the blood pressure, they may reduce, they may not increase, but coming to normal will be unlikely, because, you know, there are changes in the peripheral vessels and all these things. when muscular disease occur, or there's a calcium deposit in the peripheral vessels. But the bone pains, the muscle weaknesses, the psychological conditions, they just, as you said, they just say, doctor, I cannot tell you how I'm feeling it. So that kind of thing.
Thank you, Dr. Mishra. This was fantastic. Just one question. This is for just an intellectual curiosity. It's not really relevant to patient, this thing. So cardiovascular disease and parathyroid. Now, back in the days, we used to think that it was because of the high calcium and how calcium can get deposited in the blood vessels. But given that there are normocalcemic hyperparathyroidism with higher risk for cardiovascular disease, how do we explain this relationship between the heart and the parathyroid? Do we know yet, or is it still under investigation?
I mean, you don't really investigate so much about these conditions. Now people are investigating. Now you get sophisticated echocardiography machines. They can investigate a lot of things. One of my colleagues is also involved in the research in that aspect, in studying the myocardial changes that occur in hyperparathyroidism. People have done a lot of the studies on that also. What are changes occur in the myocardia? So there are some changes in enzymes and all these things. Is still a matter of investigation. But one thing I must say, that in normocalcemic hyperparathyroidism, you don't expect the vessel changes much. The vessel changes because of the resistance. Once there is hypertension, there is resistance, peripheral resistance. Or once there is hypertension, there is some physiological changes on the heart. That sometimes leads to little hypertrophy of the heart. So those things doesn't come back so soon. That's the point I want to tell you.
Okay, thank you. One last question. So Dr. Mishra, if you had all the funding in the world, all the support from everyone, what is the one study you would like to do on parathyroid?
I'll just do one study in parathyroid to find out that how quickly you can detect this parathyroid. Okay. Because as you delay, there's going to be more problems. So how to really pick up the cases? So I will go for a population-based study. Not very sophisticated lab study or not going, because the only thing that decides is just to take a calcium. So I need to and not to educate people. I want to invest a lot of money to educate the primary care physician.
Yes.
So no sophistication is required to know the changes that hyperparathyroidism in the body. No amount of laboratory research. I just want to educate primary care physicians. I wish to just see that how rapidly we can diagnose these conditions, because these are very gratifying result of surgery in hyperparathyroidism. You can really have seen patients that the patients develop kidney failure because long-standing hyperparathyroidism not being operated for many, many years. Young age, we have lost patients because of kidney failure.
Thank you so much, Dr. Mishra. This has been really wonderful. And we are going to, we will try to educate more primary care doctors, internal medicine specialists and all. So usually specialists are sort of aware. It's more the, the community doctors who sometimes don't have time to, keep up with all the research that comes out. Thank you very much, Dr. Mishra, and bye now.